Mr. Junaid, your screen is stuck. Can you please check
Yeah,
and
I know.
share with us?
I'm just trying to figure out this.
Yeah, please.
Now, could you see this? Is it showing?
Yes, yes, showing please full screen. Do the full screen.
Naveed, can you hear me?
Yes, yes, please do the full screen. Huh? Can you make the full screen, please?
Naveed, could you hear me? My screen is showing to you.
Yeah, yes, screen is showing, but can you please make a full screen? Yes, got it. Sounds good. You can please carry on.
We
Naveed, my screen is showing to you.
Yes, yes.
I
Yes,
think
please
it's the
carry on.
network. We can hear you, Mr. Junaid. You can proceed. We can hear you.
Assalamu alaikum, good evening, everyone. Here is Junaid Khan. I am working as a robotic surgical technologist here at SIUT since last past 5 years, and this is honor for me that I'm uh, I'm representing in this webinar, which is arranged by TORG Pakistan. So today I'm going to talk about the role of surgical technologists in robotic surgery. So here we go. So first of all, I would like to start with the term evolution in surgery. So today's in modern world, the surgery has been divided into three types: the open surgery, the laparoscopic, and robotic surgery. All these three have some advantages and some disadvantages. For example, we could see the open surgery provide a good access, but it requires a long incision. On the contrary, laparoscopic surgery solves the problem with big incision, but its access is reduced. Robotic surgery solves the both problems of open surgery and laparoscopic surgery. It provides the access of open surgery with the with exposure that is available with the laparoscopy. So now the thing is come that what is robotic surgery? Robotic surgery is basically it's a new era in the field of MIS, in the minimal invasive surgery. So robotic surgery refers to a form of minimally invasive surgery that utilizes robotic system to perform complex surgical procedures. The word here complex, that means the oncological procedures, the cancer surgeries and the pelvic surgeries. In robotic surgery, the surgeon controls the robotic arms and instrument from a console. There is a console where the surgeon sits and he controls the robotic arm and the instruments. So benefits of robotic surgery. The robotic surgery is beneficial both for the surgeon and most importantly for the patient. For the surgeon, the robotic instruments, they are small, fully restricted instruments. They have 7 degrees of freedom of movement. The image is in 3D, which is magnified 10 times than the normal human eye. The robotic instruments are tremorless with high precision. It eliminates the need of any assistance for holding the camera. And these are the some advantages for the patient, that they have improved cosmetic outcomes. That means the patient doesn't require any long incision, just small cuts are required, so they have cosmetically very good outcomes and it looks better. Shorter hospital stay, it ultimately reduces the cost of the for the patient. Advanced infection control, less exposure to infections, faster surgical recovery time, reduced blood loss and transfusions, rapid return to their normal regular activities. So here I would like to share our experience, our SIUT experience with the robot. So we have, so there are many robotic companies and many others are in the pipeline, but we experienced with the two robots. The first one and the renowned one is the Da Vinci surgical robot, which is USA based, and the other one is Versus Surgical Robot from CMR UK. The Da Vinci surgical system. The Da Vinci surgical system has three components: the surgeon console, patient card, and vision card. The surgeon console controls the camera and the instrument while viewing the anatomy in 3D view. The patient card, which is on the bedside, and it bears the camera and instruments. The vision card that makes the communication between the surgeon with their team. And this is the overall ports and instrument which is required in Da Vinci. Now the Versus surgical system. The Versus surgical system here at SIUT, it's installed in 2021, and we have we have six units, four clinical, one for dry simulation, and one for wet lab. And till now, we have performed more than 2,000 surgeries with Versus system. It has five components: surgeon console, the visualization bedside unit, the arm of the robot, the instrument bedside unit, IBSU, the endoscope camera, and the endoris instruments. So the surgeon console, in Versus, the surgeon console is the control center, and it is very flexible and convenient that the surgeon can either sit or stand by their own convenience. And the robotic arms of the Versus are known as bedside units. These are of two types: instrument bedside unit, which holds the instrument, and the visualization bedside unit, which bears the camera. And the camera one is always should be white, and but instrument bedside unit comes in 6 different colors, and this color coding is designed to these arms just because of their identification and for their understanding. Robotic instruments. So basically it is a new technology, so they have a limited number of instruments. They have just only 6 instruments. Out of 6, these 3 are energy using instruments like monopolar curve scissor, monopolar hook, and bipolar Maryland, and other 3 are non-energy instruments like curve scissor, needle holder, and fenestrated grasper. The Versus endoscopic camera, it has 3 components: the camera head, the endoscope, both 0° and 30°, and the light source. Now, as I talked that the robotic surgery is superior somehow than the normal open and traditional laparoscopy, but it also has some limitation. And here we surgical techs play a crucial role. We overcome the limitations that the surgeon are facing with the robot, and they have these sorts of limitations that they don't have no tactile sense of tissue. That means the surgeon can't have the sense of tissue, that how hard, how soft, or how hard the tissue is that. And the surgeon can't do broad sweeping motion. It means that surgeon can't do the broad motion. Robotic instruments are light in weight, so can't lift heavier tissue. So the instruments are very light, so the surgeon can't lift any organ or any tissue by himself. So he asks from his assistant or from the surgical techs to do this job for them. Unavailability of any energy device, ligature or harmonic for sealing small vessels. In oncological procedures, there are multiple vessels, so energy device must be used like ligature or harmonic, but it is lacking in this system. So we do this manually. Inability to switch instrument by their own as well as operating field. The surgeon can't switch their instruments multiple, like we have discussed the 6 types of instruments. Surgeon can't exchange their instrument by their own. So we surgical techs help them to do this thing. These are some limitations, and these are also our works that we assist the surgeon by hands-on role. So now the term. So now we have come to the actual point, that who are surgical techs and what are their roles and responsibilities. So basically, surgical techs are incredibly important because they prepare operating rooms, they organize, they maintain and organize a sterile environment, they assist surgeries, they troubleshoot anything which occurred during the case or prior to case. So they have a very crucial role in robotic also. So role of surgical techs. So surgical techs has received training in the basics of open as well as in MIS like laparoscopy or other minimal invasive surgery principles and techniques for all endoscopic surgeries. And traditionally the OR tech is confined just with the theater preparation, arranging the equipments, maintaining the sterility, just passing the instrument to the surgeon, and we don't have any direct interaction with the patient. But the dynamic has been changed in robot. In addition to all these, the surgical techs have a hands-on role. They are directly assisting the surgeon during a procedure. For example, they may help to do retraction, suctioning, applying clips, cutting tissues or suture, and these all the things we do by a hands-on role which the surgeon has previously doing by their own. But due to the limitations of surgeon with the robot, so we do this remaining work for the surgeon. So for every surgery, we see that there are three phases for every surgery: pre-operative, intraoperative, and post-operative. Our roles and responsibilities has also been divided in all and observed in all these three phases: pre-op, intra-op, and post-op. So, in pre-operative role, what we play, we do trolley preparation. We always keep backup of open surgery as well. So, in case of any emergency, any alarming situation, we don't need to rush. We always have a backup plan. We do connection between the console with their bedside unit, because the console is the control center where we give the power to these robotic arms. Dripping of the robotic arms has been accomplished to maintain their stability, self-testing of equipment, and proper patient positioning. So these are our pre-operative role which we do in the OR. And this is some pictorial presentation of our pre-operative preparation. This is in first picture. First picture, you can see that we are doing the draping, and we are doing the cabling as well. And this is how our OR looks like after done with the pre-op preparation. And after done with pre-operative preparation, we do some checklists, some WHO recommended checklists, and some robotic specific checklists as well. And we do this checklist in all the three phases: pre-op, intra-op, and post-op. Now, in the the intraoperative role of a surgical tech in robotic surgery is much more than the normal open or laparoscopic surgery. We do scrubbing and dripping of the patient, assist in port placement, assist in port placement and closure as well, and it's very important role positioning of robotic arm, which is known as the docking somehow, wide balance of robotic camera, and we assist the surgery. Now the port placement. The port placement can may vary from patient to patient, procedure to procedure, and surgeon to surgeon. It all depends upon the case and the patient's own BMI. But so it is very hard to difficult to define or to frame any specific guidelines for port placement for each case. But broad guidelines are framed to understand the basic principle. So here's the basic principle, that the port should maintain the 90-degree. It doesn't make any oblique track because it restricts the robotic arms movement. The camera port should be in alignment with the targeted anatomy, and it should maintain the 10 to 20 centimeter distance from the target anatomy or where we have to work. Right and left robotic arm port should maintain 8 centimeter distance from each other, and from the camera port, the assistant port as well maintain 5 to 10 centimeter distance from each port. So this port placement and the distance maintaining is crucial, because if we avoid this distance maintaining and we fail to maintain this distance, so what will happen? The robotic arms will clash with each other, because they have 3 or 4 arms, and they have to maintain. If we maintain a distance, so the robotic arms, they also will make the distance. Now the term docking. The docking can be defined as moving from the current position to a desired position while following a safe trajectory. The simple thing is that the docking, that means the attachment of the robotic arm with the ports. This is called docking. So we attach the robotic arm with the ports in an appropriate manner. This is called docking. And in the docking, there are some steps that we position the operation table, stabilize the bedside unit, adjust the height according to patient's BMI, position bedside units or robotic arms over the patient, attach arms with the ports, and then we do some tabs that we first select orientation. Then we do some port training. We create a fulcrum so that can help the robotic arm to we actually in port training we create a fulcrum, and we design a destination where the robotic arm have to work. We adjust, we do some adjustment, and then we give it to the surgical mode. The surgical mode, that means that it is now in the surgeon's control. Here is an example of a case, pyeloplasty. Pyeloplasty we do with the we do it is a reconstructive surgery. We do the between the kidney and ureter, and here for this procedure we keep the patient in lateral decubitus position, and for every surgery, for flank surgery we always keep patient in lateral position, and for pelvic surgery we keep the patient in Trendelenburg position. And after done with position, we place these ports. In this case, we place 5 ports. Three are out of these 5, 3 are robotic ports and 2 are assistant ports. The greenish one, the 11 is of camera one, and 6.8 are of R1 and R2 ports. These two 5 covidin ports are two assistant ports, one of 12 and other one is of 5 So these 5 ports we place in for nephrectomy, for pyeloplasty, and for every kidney surgery procedures. And this is how we this is a docking. That first we position the patient, then we place the ports, and then we do docking. This is docking, that these robotic arms are attached with the ports. And this is how we do our actual work. We assist the surgeon. Here you can see that female surgeon is sitting on a console and he is operating from his joystick, and here we are sitting and we are assisting the surgeon. 2 assistants are required at a time to assist the surgeon. And these are other examples of cases we have done in our centers. LAR, APR, etc. These are our routine cases we do with the robot. So learning curve of robot. So like with every technology, there is some learning curve. You can learn by many trial and error learnings, and you can you have some time. You give some time to yourself to adopt that technology. So it is a data of our initial 50 cases on and of setup time that we have all do draping and all connections. And on the first case it took us 60 minutes for doing all the setup, but on the 50th case it just come to 10 minutes. So what does it mean? It means that we have learned over the period of time after many trial and error learnings. So like with every technology, there is some restriction, there is some limitations, but as you grow up, as you do multiple surgeries, so your confidence will build up and you will acquire that skills. Now the post-operative role. In post-operative role, we assist the closure and dressing of the wound, undraping of robotic arms, and disposal of expired instruments. Robotic instruments have that feature that they have specific lives, either 1, 2, or 3 maximum. So we have we check after every surgery that either its life is remaining or not. If their life is run off, so we'll discard that, and if its life is still remaining, so we will send them for sterilization. Instrument reprocessing is done for those instruments which life is remaining, and place the bedside unit or the robotic arm in storage place. So this is how we do the unwrapping of the robotic arm. This is our cleaning process. This is how we do rinsing, the cleaning, and the and we do the drying of instrument with the different guns, the air gun and water gun. And now then we send it the instrument which life are remaining for sterilization. And we do 2 types of sterilizer. We have 2 types of sterilizer. Plasma sterilizer is done for those instruments which are for those instrument which are heat sensitive, and which are and those instruments which are heat liable for, so we send them for autoclave. So now we come to the conclusion. So the conclusion is that the robotics is the future of surgery, and with advantages that outweigh its disadvantage. That means that robotic surgery has no any disadvantage. It has multiple advantages. It has no disadvantage. The cost is the sole and only disadvantage of robot, but it doesn't have any other disadvantage. It is the potential to expand surgical treatment modalities beyond the limits of human ability. That means that we can do those procedures which are difficult to perform with a laparoscopy or open surgery like pelvic surgery or cancer surgery. So we do these types of procedure with the robot very nicely. The surgical techs must be proficient in setting up of equipment, good hand-eye coordination, and have broad understanding of robot. The surgical tech or robotic technologists who are assisting the surgeon, they must have the knowledge of open surgery, laparoscopic surgery, and they have very good and hand-eye coordination. They have very good skills because the surgeon is relying on them, and they have and a certain trust on them. So they must have very be proficient. The role of surgical techs in robotic surgery improves the surgical techs' work and develop many new future opportunities for them. Uh, uh, by the time as technology is changing, so robotic surgery has also grows the worth and improves the worth of surgical techs, not just on the national level, but on the international level. There are many job opportunities for surgical techs who have the robotic surgery experience. So here I conclude my presentation with a quote of Bill Gates that we are changing the world with technology. Thank you so much. And any question, please? I would like to answer that.
Thank you so much, Junaid Khan. I have a question regarding this topic. How
Yes.
you can make the sterility in your patient area? Can you tell me about this one? In the
Yeah.
procedure room, how you can
So
make the sterility?
yeah. So for sterility, it's like for the drip with patient, we do the normal dripping as we do in open surgery and laparoscopy. For robot, we have special drippings like we do for camera one, and for robotic arms we do disposable drippings, and after the case we dispose that dripping. So all the things in the OR which like and everything which is related with the patient is in sterile. The ports which we are using, the robotic arms which are the robotic instrument which we are using, all are sterile, and we are either they are plasma sterilized or they are steam sterilized, but they are sterilized. And robotic arms, as I told you, that we do the drippings, and this is one time used.
I want to
Okay,
ask a
and
question.
what? Yes,
Yes,
yes, ma'am,
please.
please. Yes. You are using the disinfection system for the system or no? For the system disinfection.
Yeah, we don't use any disinfectant. We just use surface disinfectant like quaternary ammonium compounds for cleaning the surfaces. We do plasma sterilizer like H2O2, hydrogen peroxide steam sterilizer, and we for heat liable instrument we do steam sterilization like autoclave at 133 degree.
All right, all right. Thank you so much. Thank you so much. If you have any question, please you can.
Yeah, please let me know.
Well, I have a question,
Okay.
please. Sorry. Well done. The
Yeah.
question is similar to what you asked. When it cannot lift heavy tissues, that means it has a limited surgery that it can perform. So what are the limited surgery? I know you are not the surgeon doing it, but you are just technician to arrange to do some things and know the technical know-how of how the machine works. But I want to ask, what are the limited surgical interventions that it can do? Because you said it cannot carry every tissues. It can't carry every tissues. So
Yeah.
what are the limited surgery? Yeah, what are the surgeries that it can perform?
So, the first of all, with the robot, there is no limitation. The surgeon can do every procedure and perform every surgery. But when it comes to the when it comes to the any tissue or any organ which is heavier, so we just lift them. There is no any contraindication, or there is no any limitation with the robot but they have the limitation with the instrument as well. They don't have any energy instruments, but in other we are using the Versus system. But in Da Vinci there is energy instruments, harmonic, legature. They have stufflers as well, they have hemologs as well. So they have all the things. The Da Vinci one is just fully equipped, they have all the things. But in Versus, which is SEMA UK based Cambridge Medical Robot, in this system there is some limitation. They have they again, I'm telling you, there is no limitation with the robot, but there is a limitation with the instrument, that they can't hold the heavier tissue, and they don't have any energy device. So here our center, which where we perform basically urological cases and general surgery procedures. So we do all kinds of surgeries, and because our surgeons are not as trained, so we do hybrid procedures, like for example some part with the laparoscopy and some with the robot. So we do hybrid procedures.
Yeah, well done, sir. I want to ask about
Yes,
this.
please.
Okay, sir. Is it possible to use the robotic surgery in neuro cases too? In neurosurgery?
Yeah, a neurosurgeon, we don't have that specialty, but the neurosurgery, I don't know the actual data of that one, because we don't have that specialty. But I heard that some biopsies are taken, but thoracic surgery is performing, but neurosurgery, I don't have much information about that.
Thank you, sir. You appreciate it, sir.
I'm sorry.
Thank you, Junaid Khan. Thank you so much. So, for the closing remarks, I would like to invite Miss Adi. Miss Adi, please.
Thank you so much, Mr. Junaid. That was a brilliant session, very informative and very relevant to knowledge. I just want to speak on, just to add to what has been said already. Someone asked a question in relation to neuro procedures for robotics. In Ireland, yes, it's done, even though it's only a few centers, because it's very, very specialized. And as we all know, maintaining the robot itself could cost millions of dollars or millions of euros. Either you use it or not. So it's a lot for every facility. So only limited procedures are utilized with that, and sometimes you have to have the patient that can afford that as well. Some spinal procedures, they utilize the robotic technology for some spinal procedures, very minimal levels, not just like 14 level fusions or things like that. So when they want to treat scoliosis, degenerative disc disease, spinal instability, my previous specialty, I was in orthopedics and spines, and all these things, they do them a lot. So for spinal fusions, minimal levels, kyphoplasty, decompression procedures, they could, for alleviating spinal stenosis, herniated disc, they could utilize the robotic technology. And for biopsies that Mr. Junaid mentioned, like for brain tumor resections, pituitary tumors, they could utilize robotics as well. Epilepsy surgery, like resective, use of lasers, LITT. So they could use that. Again, it's very, very specialized. And the skill of the surgeon needs to be considered as well. And the surgical team, they need to do that. Sometimes they have to fly people out of the country to do the comprehensive robotic training before someone can actually be assigned into that operating theater. So it's a very, very specialized field, and it depends on the competence, on the skill of the surgeon and the surgical team as well. Because the disadvantage is that some operating professionals when it's being utilized, because some of those procedures, especially if it's a general surgery, if it's gynecology, it could take a while, and some people could find it maybe not interesting, even though it's very, very interesting if people are interested in that. But sometimes it could really, really take long depending on what they are doing. And more still in neuros, they utilize that endoscopic procedures like ETVs, like cyst and intracranial cysts. They utilize the cranial decompressions. They use that to clip aneurysms and more. So it's something that we could also look into. Then I would also like to recommend that if you don't mind, Mr. Junaid, maybe at some point we could have a part 2 of this session whereby maybe you can record or show us a video of actually how the robotic arms are draped, because I think I'm interested more in that, and I would really like people to see the draping technique, because I know it's very, very technical. People need to be careful, especially in terms of contaminating aspects of the arm, in terms of lifting yourself, or I know it's very, very technical. So if there can be like a short video whereby
Yeah.
it's demonstrated, or even if you could do it later after this session and send it to us, and we can add it to the replay of the video, if you don't mind. Do you want to say something, Mr. Junaid? I think you wanted to
Yeah,
say.
I'm saying this, that I will must, and I will share that draping video on your page. And
Okay, thank you so much. So if we can have that, then we can include that with the replay of the session to make it more comprehensive, because it's part of the role of the surgical technologist or the nurse that they need to know how to drape that, because if the draping is contaminated, then that procedure is not going to take place. And if
very
possible,
hard sterility. Yeah, exactly. It is
yeah.
very hard for us to maintain it, but we know the infection transmission, and because we are educated and we are much more being trained, and we have that special training, so we have that idea that how we can avoid these things.
Okay, thank you so much. And one more thing, if we could have like a 2 to 5 minutes recording as well, of the instrumentation of that. For example, maybe you could list, I know you showed the picture at the very beginning, so but if you could hold one of it and just say, oh, this is that, the name and what the scrub nurse or the surgical technologist would be looking for when they want to use that, or before, because the surgeon would be blind, let me put it that way, it would be blind. So the nurse or the surgical technologist scrubbing for that procedure needs to be able to identify things, some parts, so that to avoid, to prevent wrong connections to the arms of the robot and things. So if you can just hold each instrument one by one and just mention, oh, this is the name of this is what the nurse should look for, the surgical technologist, because basically the role of the nurse and surgical, they are like intertwined in a way. So thank you so much for that. We would really love to have that as well. Thanks for
And
sharing your
thank,
knowledge.
thanks to you as well, and thanks to all the participants who take
Yeah,
their time to join this webinar. And special thanks to you that you have created this platform where we connect with other techs as well and other nurses as well. So thank you so much to you. And
yeah.
we will meet with another webinar with you. We will conduct another webinar with you.
Yeah, thank you. Thank you so much, Mr. Junaid. Thanks for that. And I really want to say thank you to the executives of the Pakistan chapter. Thank you, Mr. Naveed, our secretary, for facilitating this session. I know we are working on having a partnership with King Edward Medical University in Lahore, Pakistan. That's the Department of Allied Health Sciences. So that for these things, when we have a formal partnership, we could have a few TORG members from different countries. We can have a trip, a very short trip. Let's go into those labs and see, have a first-hand experience. Come to your hospital, have a first-hand experience with this thing, even if it's 1 week internship or something. I know it's achievable. I know we can do it with. So we are working on that so that we can just take this knowledge from that and capitalize on that. Thank you so much. Thank you, everyone.
Thank you so much.
Sure.
Thank you.
Thank
Thank
you
you,
so much. Thank you,
everyone.
ma'am.
And have a nice day ahead.
Thank
Yeah,
you,
thank
sir. Thank you, man.
Bye. Bye, Mr.
Bye
Ajbola.
bye.